You're welcome to my channel. Thanks for visiting. Today is going to be all about Meperidine under the brand name Demerol. Without further ado, let's go. Why this presentation? Someone may ask. Well, it is true that Meperidine has been prohibited in some countries, or it is less prescribed or used. But I cannot relax because there's that high chances of medication error while administering meperidine or demerol. Also, the metabolite, that is normeperidine, is extremely toxic, particularly neurotoxicity. In addition, there might be problems that could lead to serotonin syndrome. All these will be addressed in the course of this presentation. Truth be told, like I've said earlier, that this medication has been prohibited in some countries, but it is not completely true. In some parts of the world, it is still not discontinued, and it is still available. Some formulations might have been stopped as per production, but other formulations are there, and the rest are still available anywhere you seek it around the globe. Even where it has been banned, some citizens are still using meperidine. In other words, it is difficult to relax assuming that because it has been prohibited in few countries, then we are out of the wood. That is not the case. The truth is, meperidine or demerol is with us. Some are still using it. So, why are we bothering ourselves? Yes, we have to, because there must be a way out. And the way out is, let's get it right and be saved. And that's why I'm here. So this presentation is based on the assumption that meperidine or demerol could be prohibited even in some countries, but people are still using it. And if that is the case, if that is the truth, let us use it safely. And that is why I'm here. So follow me. Let's get all the facts about meperidine. Before delving deeper, let's consider some facts. Please, anyone on opioids generally should be ready to call 911 whenever he or she is feeling strange. To be precise, when your breathing becomes irregular, you feel like fainting, maybe you've had seizures in your back, or you are clumsy or drowsy. If care is not taken, you might go into coma. Then, you won't be the one to call 911. In Overdose by accident, if you are still able to talk, please get someone to call 911. Administer Naloxone if it's available. But if you're already in coma, you are at the mercy of whoever is around. Can we prescribe Naloxone with opioid? Go along with whatever is obtainable in your jurisdiction. No two people are the same. So, don't share medication, please. I'm pleading with you. Like your friend is taking Demerol for whatever reason, and you think you have the same condition, and you're begging for it, or you are on Demerol and you are sharing it, or you are selling it. Please stop it. It's killing. Let's go for smallest dose of meperidine for the shortest period of time. Dose is a factor of age, weight, route of administration, experience of the individual that is using this medication with other comorbidity conditions. Still on first note, to prevent further deaths due to misuse, abuse, or addiction, I will not be giving specific or precise examples of how or when we can use Demerol. For moderate to severe pain, yes, but it's not the first line medication when it's all about pain treatment. No, not the first line. Be careful, stay healthy, stay alive, don't do drugs. Avoid this medication in neonates. You should be cautious in anyone less than 18 and even the elderly. Please be careful. Respiratory depression is pretty possible. Neurotoxicity is another issue with associated delirium, and that is associated with the metabolite, Normeperidine. Avoid this medication like plague in renal failure. Why that? The fear of neurotoxicity. This medication could come under different brand names. You can check the one that is available in your jurisdiction here. It belongs to the class of medication known as synthetic opioid analgesic. So, it is an analgesic. It is a synthetic one, synthetic narcotic analgesic, and it is an opioid. So, put together, it's a synthetic opioid analgesic. Uses of meperidine or Demerol. For pain management, remember it's not the first line, and it's for moderate to severe pain. Let's use this for short term only, please. In case of rigors or postoperative shivering, we can go for low dose of Demerol, and we use once. It's not what you prescribe PRN and be taken 2 or 3 times daily. No, once. For sedation, preoperatively. Also part of uses will be for regional anesthesia, preoperative, like sedation the other time, even postoperatively, and sometimes in drug reactions, like in the case of harmful terrorism B. Why not using morphine if we have too much controversy over Demerol? Well, meperidine, when compared to morphine at similar dose, will have more advantages. It is faster when it comes to onset of action, shorter duration of action, less smooth muscle spasm, less constipation, and less respiratory depression. Contraindications. Hypersensitivity. When there is history of hypersensitivity reaction to Demerol or meperidine in this individual in the past, we will not use it today. And also, history of hypersensitivity to any component of its formulation means we cannot use Demerol or meperidine or petidine today. But the hypersensitivity has not ended. If there is history of hypersensitivity reaction to any of the opioids in this man or woman, then today we should expect cross-reactivity. So we will not give another opioid called meperidine today. We will not make that mistake to prescribe or give meperidine to anyone with gastrointestinal tract obstruction or paralytic ileus. Why that? I will tell you more in a bit. In the case of severe asthmatic attack or chronic obstructive pulmonary disease or any respiratory disorder that is affecting the breathing, then we will not give meperidine because on its own, it's going to cause damage to the respiratory system. In what form or forms can we get meperidine? In form of solution for injection as hydrochloride. In that case, we are going to get this strength under the brand Demerol. In form of solution for powder used as hydrochloride, and we're going to get this strength as generic. In form of tablet for powder used as hydrochloride, and we'll get this strength under the brand Demerol. Administration. Let's consider the dose first. There's no flat rate dose for particular age or gender. Why that? We have to consider why do we need this medication. So the reason for its use is the first thing to be considered. And then the route. Are we going to go through the oral or parenterally? But if you use this medication for oral, there will be poor oral bioavailability. Therefore, we prefer parenteral route often. Then we'll consider whether this individual is a naive user. Naive user will take lower dose compared to experienced or chronic users. How about the age? This is a child or this is an elderly man or woman. Then we'll go for lower dose. Why that? The rate of elimination will be lower in them. We have to consider the weight, but don't overload anyone because of the weight. Find out what the appropriate dose should be. Then, is this individual frail? Might be because of long or chronic disease, malnourished, or debilitated. If that is the case, be careful. Metabolism might be impaired, and you get into toxicity no more. So in debilitated, malnourished, or frail individuals, we go for very low dose. Still on administration, let's remember that this medication will have short half-life. So put it at the back of your mind that this medication will be there in a system for 2 to 4 hours. Some put it at 3 to 4 hours. And the metabolite will actually last longer, as long as almost a day, 21 hours. In liver failure, then the half-life will be prolonged, like 12 hours instead of 2 to 4 hours. It is excreted by the kidney. 25% as normeperidine and 5% are unchanged, and these will be determined by the pH. The unchanged form in acidic urine, while the free or conjugated one in alkaline urine. Still on administration, we have to add the oral solution to have a glass of water before being used. And we must use a calibrated device to get the precise dose. That is one of the reasons why I'm making this presentation. Because you have to get the precise dose. So use calibrated device that will come with the medication. Don't use teaspoon to measure, please. Don't use tablespoon to measure Meperidine, Petidine, or Demerol? No. And finally, on administration, intravenous dilute the solution, please. If you want to give it intravenously, push slowly, okay? No rapid intravenous, no push, no. Slowly for at least 5 minutes at the rate of 10 milligrams per ml or even less. The patient preferably should be in supine position for about an hour or more. Why that? That will prevent dizziness, nausea when the head is moved around. No rapid IV push, please. The subcutaneous should be given undiluted. Intramuscular will be the better route for repeated dosing, and undiluted, and please go for large muscles. Now, you may prescribe this medication along with laxatives when you want to deal with constipation, along with antihistamines when you want to prevent itching, and with antiemetics when you want to subdue the nausea and vomiting. In case of inadvertent overdose, let's go through the symptoms that we are going to find or signs. Hypotension, bradycardia, weakness, respiratory failure associated with breathing difficulty, shallow breathing or slow breathing. Maybe seizures, cyanosis, itching, cold extremities, nausea, vomiting, constipation, confusion, drowsiness, or coma. How do we treat this? Naloxone. First, do that by yourself before you become comatose. But if you're in coma, let's hope that you'll be fortunate enough to have family, friends, or someone passing by who will be able to help you with the administration of naloxone and call 911. Then the poison control center should be called. Find out what that number is in your jurisdiction. Or if you are in a rural area, just go with naloxone or find someone to take you to the emergency room. The history of biodata, your age, gender, everything will be taken. The history as per the circumstance, is it inadvertent ingestion or deliberate? What is the dose? Then, is it an accident or this is attempted suicide? Any other medications ingested at the same time? Did you get this on the street because of the fear that it might have been adulterated with fentanyl or amphetamine? We'll take vital signs and repeat the same, periodically. And toxicology screening will be done and followed, whatever the outcome will dictate. Certain gadgets will be on, and then appropriate IV fluid will be placed off. Some will go for another antidote or activated charcoal. And then laxative or ventilator might be used as it is appropriate. Mechanism of action. Meperidine is an opioid receptor mu or kappa opioid receptor agonist. Here, adenylyl cyclase will be inhibited. Then, when that happens, cyclic AMP will be dropped. Nociceptive neurotransmitters like gamma aminobutyric acid, dopamine, substance P, acetylcholine, noradrenaline release will all be halted. When that is stopped, ascending pain pathway will be inhibited, and it will also alter the perception of pain. Remember, we use it mostly for pain management, okay? Moderate to severe pain, and is not the first line. With generalized central nervous depression, there will be hyperpolarization and reduction in neuronal excitability. It binds to opioid receptors in the intestine, leading to constipation. How? How can it cause constipation? Let's examine that. How can opioid like meperidine cause constipation? It's going to, make use of new receptors along the gastrointestinal tract. Then the expected normal peristalsis will be altered. The altered peristalsis will be essentially that it's going to slow down. When it slows down, that will afford the system to absorb water from the content of the gastrointestinal tract into the circulatory system. Then the content, meaning the stool, will become harder and harder the longer it stays in the gastrointestinal tract. The anal sphincter tone will be increased. Defecation will be impaired, and hence constipation. But how can we get out of this? You can use laxatives, or the individual should drink more water, or high fiber diet, or exercise. All these will help. Still on mechanism of action, new opioid receptors will be used by meperidine just like morphine to deal with pain. Kappa receptors will be used to handle shivering, and sodium channel will be blocked to act as local anesthetic agent. It has the capability to inhibit that is dopamine transporter, and NET, that is norepinephrine transporter. And when that and NET are inhibited, it will play the role of a stimulant. So, meperidine can handle pain, can handle shivering or rigor, can work as local anesthetic agent, and as a stimulant. That is why it's been abused. Adverse reactions. Cardiorespiratory depression, leading to bradycardia, hypertension, shock, cardiac arrest, respiratory failure, or respiratory arrest. In central nervous system, can lead to headache, hallucination, agitation, confusion, delirium, dizziness, sedation, seizures, increased intracranial pressure, or muscle twisting. Still, adverse reactions will include hypersensitivity reaction, urinary retention, tremor, or weakness. Part of adverse reactions will be along gastrointestinal tract, causing nausea, vomiting, constipation. How can we monitor? Monitor with vital signs. Know whether it's affecting the cardiorespiratory system or not. Is the pain going down? Is the individual developing tolerance to it? Is it being misused by this patient? Any sign of abuse? Is he or she addicted to it already? And of course, what about the side effects? Drug-drug interaction. Let there be 2-week gap with monoamine oxidase inhibitors. Let me explain. If anyone will be taking any of the monoamine oxidase inhibitor and he or she is taking meperidine today, meperidine must have been stopped and not to be used for 2 good weeks before taking any of the monoamine oxidase inhibitors. Still, on the other side of it is, if anyone is already taking monoamine oxidase inhibitor and would like to take meperidine, he or she must have stopped taking monoamine oxidase inhibitor for at least 2 weeks before the use of meperidine to them. Alcohol will aggravate the side effects, meaning it will make it worse. Opioids with street drugs will be extremely dangerous, and it could lead to death. Usually, I don't touch drug-drug reaction. I will always tell you to contact a pharmacist or clinical pharmacologist, but I decided to bring out these 3 so that I won't leave the job for someone else to do. Now, warnings. Anyone on this medication can develop tolerance. This medication could be easily misused, could be abused, and one could develop addiction to it. There may be overdose that could be inadvertent or deliberate in the case of attempted suicide. There may be severe cardiorespiratory depression and so many other complications that could lead to death. Still on warnings. Naloxone is good, but it can worsen a known neurotoxicity. History of substance use disorder is very necessary in this patient personally or in his or her family. Why that? We want to know whether this individual can easily abuse this medication, or the overdose we are faced with today is as a result of suicide attempt. Normeperidine, the active metabolite, is a central nervous system stimulant and makes neurotoxicity to get worse. Constipation, just like in other opioids, is a possibility, but you can always add your laxatives. Remember, lower blood pressure or orthostatic hypotension or syncope could be developed. So in an individual with orthostatic hypotension already, and you are prescribing meperidine, then watch out. Still on warnings, central nervous system excitation is a possibility with this medication or with its metabolites known as normeperidine. I've said earlier that normeperidine, the active metabolite, is a central nervous system stimulant, and that could lead to seizures, anxiety, or tremor. Still on warnings, there can be respiratory depression, and then sedation is possible from carbon dioxide retention. Long-term use can lead to build-up, and that build-up can lead to tremor or seizures. Serotonin syndrome is a possibility when it is used with certain medications like selective serotonin reuptake inhibitors, tricyclic antidepressant, SNRI, that is serotonin norepinephrine reuptake inhibitor, lithium, monoamine oxidase inhibitors, or triptans. Serotonin syndrome with meperidine is not common, but when this medication is used with any of these, then there might be serotonin syndrome. Still on warnings, please be cautious when there is head injury, where there is organ failure, like liver failure, metabolite is impaired. When there is kidney failure, excretion will be impaired. When there is delirium or benign prostatic hypertrophy or cancer of the prostate, be cautious. In hepatic impairment, like I've said, or even in adrenal insufficiency, cautiously please, in pheochromocytoma, be careful, and of course in psychosis. Still on warnings, meperidine can cause seizures on its own, and it can worsen the existing seizures. People with sleep apnea should not use this medication because they might die from respiratory failure in their sleep. Vagolytic effects may lead to increased ventricular response to supraventricular tachycardia. Still on warnings, low dose is expected in lean, frail, severely ill or debilitated people and elderly. Low dose, please, including children. Gasping syndrome is possible in neonates. This is a different entity that I'll talk about later. It's as a result of using benzoic acid as part of the formulation. Have antagonists ready. Get your naloxone ready before giving this medication intravenously. Even then, you give slowly, please, at least over 5 minutes. For the small dose, like I've said earlier, go for the smallest dose for the shortest period of time. And never, never stop cold turkey. If you stop cold turkey, you run to withdrawal signs and symptoms. Still on warnings, let men and women of childbearing age know that long-time use can lead to sexual dysfunction or infertility, and that will be due to secondary hypogonadism. This medication, known as meperidine, should be off the table for pregnant and breastfeeding mothers. Why? We cannot determine its safety. Withdrawal symptoms is possible in the newborn. Withdrawal. What will happen? Well, you will be faced with withdrawal signs and symptoms. But how do we get here when you stop suddenly? So don't stop suddenly. No cold turkey. If you want to know more about withdrawal signs and symptoms, you can kindly click on this link. But if you don't mind, if you don't want to click on this link, I have copied and pasted what you're going to find through this link right here. So you can continue listening here. Let's take note of the fact that this is not expected to kill you, but it could be very unpleasant. It is better to seek help, like detoxification or rehabilitation, and that will help tremendously. Also remember that no two people will be exactly the same. Still under the first note, the severity of the withdrawal signs and symptoms will be based on how high the dose of meperidine you've been taking. For how long have you been taking it? Has your body adjusted to it? Are you taking it with other substances? How about your health status generally? Do you have psychiatric disorders? Have you developed tolerance to it? Are you dependent on it? Have you been abusing it, or are you addicted? All this will determine the level of severity of the withdrawal signs and symptoms. Also, the first phase of withdrawal signs and symptoms will be the first 10 days, and this is called acute withdrawal symptoms. The second phase will be days after the 10 days. That will be post-acute withdrawal symptoms. Post-acute withdrawal symptoms can last 2 years or more. The expectation is that the intensity will be inversely proportional to time. Let me explain. The longer you are from the day you stopped, the lesser the severity of the signs and symptoms. Now, let's go through the sequence order. I place this as order A, the first thing that will happen. The fact is, you are already on Demerol, but you stopped, either you stopped cold turkey or you've been ordered to stop gradually. The first 2 to 5 hours of throughout the day, something will happen. You'll still be craving to have the medication. You'll still be craving to have the Demerol or Meperidine. There will be efforts that you are going to put into it, and you are going to seek to get the drug to be used by all means, including stealing, you know, begging for money to get it bought, going to doctors to tell lies to get it. Then you can have nausea, vomiting, runny nose, shortness of breath, your blood pressure may rise, can become irritable or agitated. You become restless and having difficulty to sleep, and you might even become anxious. The sequence order B will be that at 48 hours, that is 2 days to 5 days, you'll still be craving to have the drug and you'll be seeking to have the drug by all means available to you. Your body will start reacting at this time, and that will be muscle pain, headache, chills, you'll be sweating profusely, you'll have dry mouth, become apprehensive, and you can have hallucination or become paranoid. You can have shortness of breath with all other factors under sequence order A. The sequence order C is that at day 6 to 10, acute withdrawal symptoms will end this time. Then everything under sequence order A and sequence order B will be waning in intensity, meaning the symptoms are no longer as severe as the first day to day 6 up to day 10. No, it will be going down. But you still be craving to have the drug and might be seeking to have it as well. Now, sequence order D. At day 11 and greater than that, you will then be faced with post-acute withdrawal symptoms, and that will start. Then you can become depressed with characteristics of depression, and at this stage, we have to watch out for suicidal ideation or attempted suicide. This is the stage that some people might, kill themselves. We become, paranoid and then be having hallucination. The expectation is that the intensity of the above will be low and will continue to abate as the day goes by. Hence, the intensity will become inversely proportional to the length of time, meaning as you go from day 11 to day 20 to 40 or 50, you might still be having the signs and symptoms, but it will be waning in intensity. I tag this as sequence order E. At this level, the expectation is that you are going to get out of all this trouble if you seek help on time. You seek help quickly, then please, if that is your choice, which is the expected choice, and that is why I'm here to publish this, then talk to your doctor. Go to the emergency room. Call 911 or 119, 999 or 112, depending on where you are in Europe, North America, Latin America, Africa, Asia, anywhere you may be. But if you want to get out of this trouble after seeking help, calling the appropriate number, or going to a doctor, don't secretly indulge yourself in taking any other drug, please. I mean, street drug. No, don't. The sequence order F will be that you might give up the ghost. That is not expected, but it is possible if you are secretly taking the drug or other drugs. I mean, street drugs. Then, if you are not seeking help, or you are seeking help but you are not, uh, adhering to the instructions, non-compliant with intervention, rehabilitation, or detoxification, that you are attending or you sign up for. If you are deceiving yourself, you are going to die. Suicidal ideation, if you have it and it's not reported, then you are going to die. So when we find out that you have suicidal ideation or attempted suicide, we are going to address it promptly. So if you have suicidal ideation or attempted suicide and the physician is not addressing it promptly, you are going to die. Please seek help. Seek help. We want you here. Your friends and family members want you. Seek help. Seek help. No more secret drug, ingestion. Don't do it anymore. Seek help. Go for rehabilitation. Go for detoxification. Seek help. Your family, your friends love you. Thanks for this short presentation. Kindly forward this to anyone you know that will need help. Appreciate it.